By applying the knowledge I gained through the IHI for quality improvement, I have developed the best way to improve the quality of care within the hospice unit for our patients. The IHI discusses the effectiveness of patient shadowing by taking the patient's perspective, stating, "When you see the care system for a patient's perspective, you'll see opportunities for improvement that might not be apparent as a caregiver." I obtained my idea for change through patient shadowing by seeing the small changes that can be done to prevent falls. It is important to always look at any change that will improve quality of care, and this change not only preserves the dignity for our patients, but also promotes safety within this population in the nursing homes. These small changes had a huge impact on the quality of their care. As a team, we all want to accomplish better quality of care for our patients, and among our biggest concern are falls. Falls was the #1 concerning unusual occurrence topic discussed in our quality assessment performance improvement meeting at the beginning of the year, next to medication safety and patient and family complaints. As a team, we are looking for a more effective care plan within the nursing home team at preventing falls. This is my aim. We cannot underestimate the decrease in quality of care that occurs when a patient falls. Oxtoby 2017 states, "By being aware of the necessity to minimize the risk of falls and taking action to help prevent them, community nurses can make all the difference to a patient's quality of life." The aim of this synthesis project is to enhance the safety of our patients by creating a more dignified environment for our patients at end of life. Decreasing falls within a care plan and being proactive for preventing falls will increase positive patient outcomes. Our goal is to decrease the number of falls for patients within the skilled nursing setting of a hospice unit. We hope to reduce the number of falls within a hospice unit setting and comparing the number of falls after implementation of this project for our next quarterly performance improvement meeting. Brink and Kelly 2015 states that falls increase the risk of death for those within a long-term care environment. Dye 2016 states that falls adds to the distress of overwhelmed patients and caregivers. Patient safety issues can interfere with end-of-life goals and comfort. To better demonstrate the risks of falls, I have created a fishbone diagram to illustrate the signs leading to falls. Delirium is one of the biggest risks of falls in our patients. Delirium can be from any change in the body, including difficulty sleeping. Morphus, Schwartz, and Salusi states recurrent falls occurring exclusively at night are caused by rapid eye movement sleep behavior disorder. Any sleep disorders, such as insomnia and nightmares, can lead to delirium and increased risk of falls for elderly at night. Lack of prevention, lack of knowledge, unmanaged delirium, and increased weakness can lead to falls as seen within this fishbone diagram. To facilitate a strategy for the needed change to reduce the number of falls that occur at end of life, I have created an algorithm to assist with implementing the interventions to reduce falls. We can address the symptoms that occur before they enhance into a fall. These interventions can be utilized prophylaxis before falls occur or after a fall occurs. This algorithm also allows for a visual to see the signs and changes in patients that can lead to falls. When patients are dying, we need to consider any changes in the body that impact a patient significantly. These interventions were thought of by my experience, by the experience of my colleagues, and by evidence-based practice. Yazdani and Hall, 2017, discussed the nurse-administered fall risk assessment instruments to allow for navigation of patient-specific fall risk factors and interventions that can be identified. There are many risk assessment models. However, the unique hospice experience myself and my colleagues have addressed allowed us to come up with the best interventions to assist in reducing falls. New onset of incontinence, increased weakness, delirium, changing condition, and a new change in environment impact a patient's risk for a fall. Within the algorithm, you can navigate and customize what interventions that can be implemented for the symptoms and occurrences that are happening for each patient. I have delivered copies of the algorithm to facility staff, recommended the appropriate fall interventions for each hospice patient within the hospice unit, and provided much education to patients, families, and staff at the facility. I have chosen my project team based on their experience within the hospice setting, assuring we accomplish our main goal, to improve patient outcomes. The 2 nursing case managers have implemented the algorithm within their hospice unit, with the social worker assisting in discussing quality outcomes of decreasing falls with facility, staff, and family. The director of QI giving me the guidance for improvement and ideas for measuring outcomes, and my manager and acting DON providing me with support and ensuring that we can implement this within the whole nursing home team in the future. I have acted as a leader within the facility, working with facility staff and ensuring fall precaution recommendations were implemented and giving them education regarding the algorithm, discussing the benefits and improving quality care. As the IHI advised, it's important to note the high influence stockholders within the change project to assure positive patient outcomes. This involves developing relationships with facility physicians, obtaining the needed help from pharmacists, and collaborating with multiple facility staff such as the DON, the ADON, managers, floor nursing staff, and CNAs to assure the interventions are implemented. Carleen and McCarthy, 2015 states, consistent and timely communication through formal and informal channels helped mitigate the implementation barriers. Utilizing the entire team was the greatest intervention to achieving positive outcomes at reducing falls. Barriers that interfered with the change intervention are staff not following through or not agreeable to the plan of care recommendations, feeling overwhelmed by excess protocols, lack of resources, and resident family noncompliance. Many facility staff were concerned to utilize a fall risk precaution status post 1 fall or prophylaxis because they felt that there will be no further interventions to implement if another fall does occur. I managed this by demonstrating leadership skills by reinforcing the importance of promoting safety within our patient-centered care. I advocated for the value of patient safety and reinforced that we don't want an additional fall to occur, and educated on the many interventions that can still be utilized if necessary. To facilitate raising awareness and interest of fall prevention and working together to decrease the noncompliance from residents, I facilitated collaboration and teamwork from other disciplines such as a medical social worker and directors, floor staff, and management. Valen, Status, Lissens, Vander Elst, Jezisons, and Milson 2017 states, in several studies, participants recognized the importance of including various disciplines with their diverse perspectives and sharing responsibility for fall prevention. Another barrier addressed was noting limited facility equipment and lack of resources from hospice. When wanting to utilize the intervention to trial a jerry chair, unfortunately there was no jerry chair available within the facility. We needed to utilize other interventions, utilizing bolsters and other cushions within the chair to assure proper positioning and preventing falls. A new hospice admission had fallen 9 times within the facility within a 3-month time span. Since patient has been admitted to hospice and the algorithm implemented, he has not fallen once. Delirium well managed and patient in good spirits. 1 fall noted on hospice admission night before implementation of the algorithm for hyperactive delirious case. Falls significantly reduced, however, did develop 1 additional fall noted to be up all night. After monitoring and treating insomnia and encouraging staff to report findings of insomnia, free of further falls. Status post-fall of another patient at night who was experiencing pleasant delirium, no interventions necessary. Became afraid at night, delirium now managed as well as preventative interventions of getting out of bed unassisted, status post-fall, and effective. Patient noted with UTI, symptoms treated early, pain managed, free of fall. Many patients with delirium also caught early, as well as respiratory distress and increased weakness that were addressed to prevent falls. There are many cases like these that falls have been prevented since implementation of the algorithm, and listed are all the falls that did occur. Quantitative data will be pulled once the next quarterly meeting will take place next month, and obtaining comparable percentages of falls within facilities to analyze the project further. Falls from previous quarter prior to project and falls from this quarter with the change project will be compared. The changes that we've made have led to significant improvement with a reduction of falls. The PDSA cycle reflects the process of implementing the algorithm and how we got to achieving these positive outcome measures. Throughout collaboration of our team, our goal is to assure we take this algorithm into our goals for positive patient outcomes in the future, not just within the hospice units, but also within all the long-term care facilities for our hospice patients within the county. I believe we can also implement an algorithm for preventing falls within assisted living facilities. Ferraro, Zernzak, Maturo, Nagy, and Barrett 2017 states the importance to continue to shape the institutional culture for quality improvement is not seen as an extra, but rather as a topic embedded in the very fabric of all health care and delivery of high-value care. We look forward to seeing the positive change within our team and improving the quality of care and furthering our goals for positive patient outcomes. Change has a very positive impact on the well-being of our patients at the end of their life within our practice. I feel that I have gained valuable, unparalleled leadership skills by implementing this change project to improve the quality of our care and promoting safe practice. Vogelsmeer, Farrell, Rome, and Ott 2010 states, the leadership supports open communication and facilitates teamwork and goal setting among staff. This was effective in facilitating the algorithm for quality improvement at reducing falls for our hospice patients within the unit. Vogelsmeer, Farrell, Rome, and Ott 2010 also states that these leadership behaviors are consistent with transformational leadership for which leaders and staff work together toward the greater good of an organization. There is always room for further improvement. As further falls have occurred, I will continue to improve the care of our patients by furthering the research of minimizing falls within nursing home setting, improving the quality and preserving the dignity for patients at the end of their life.